Hello, and welcome to this mini-gem brought to you by the Association of Elderly Medicine Education. My name is Kelly Hunt, and I'm going to talk to you about Acopia. Just say the word Acopia or social admission to a geriatrician and watch them shudder. Firstly, let's start with the learning outcomes. These are to understand that Acopia is not a medical diagnosis. That patients given a diagnosis of Acopia or social admission usually have multiple comorbidities and missed acute diagnoses, and that a diagnosis of Acopia is associated with significant morbidity and mortality. So, perhaps geriatrics isn't your chosen specialty, and maybe you feel that older people should be cared for by geriatricians. In which case, maybe you should look for a job in the hospital that only treats young people. Only, where is that? Acute medicine is actually heavily weighted towards geriatrics, with 2/3 of hospital admissions being of people aged over 65 years of age. These account for 68% of emergency medicine beds. Although older people are often described as having an atypical presentation of illness, these presentations are actually typical for older people. To be good acute physicians, we must develop our skills at assessing and managing older people on presentation to hospital. Geriatric medicine is challenging. Sensory impairment can make communication difficult, which may be further complicated by cognitive impairment. There are often multiple medical problems to assess, along with significant drug interactions and adverse effects. That then still leaves functional status and carer support to consider. Older people often rely on support from partners or families, but this can cause significant financial and emotional strain, leading to relationship breakdown. Geriatricians use comprehensive geriatric assessment to take a holistic approach to diagnosis and management in older people. Let's go on to have a look at a couple of cases. Case 1 is a 44-year-old gentleman who presents generally unwell. He has symptoms of cough, fever and generalised aches. He has not been at work for 3 days and is taken to his bed. His observations reveal a temperature of 38.4, a blood pressure of 110/65 and a heart rate of 90. He has a respiratory rate of 24 and oxygen saturations of 96% on air. Case 2 is an 82-year-old gentleman who presents generally unwell also. He has worsening confusion, poor oral intake and decreased mobility. His wife is struggling to support him at home. His observations show a temperature of 35.9, a blood pressure of 102/65, a heart rate of 110. He has a respiratory rate of 22 and oxygen saturations of 94% on air. Following chest X-ray assessment, our gentleman in case 1 is given a diagnosis of left lower lobe pneumonia and commenced on IV antibiotics. Our gentleman in case 2 has a more uncertain diagnosis and is labelled with Acopia, query lower respiratory tract infection, query UTI. Now let's review these cases. If we look at case 1's observations, we can see he scores on systemic inflammatory response syndrome criteria for his temperature and respiratory rate. His heart rate is borderline at 90. Case 2 actually scores 3 on the SIRS criteria for his temperature below 36, tachycardia and raised respiratory rate. You will also notice that his systolic blood pressure is just above 100. Both cases are failing to thrive at home, with the younger man not being able to work and taken to his bed, but only the older gentleman receives the label of Acopia. When we take a closer look at the chest X-rays, left basal consolidation is obvious in case 1, but case 2 also has evidence of right basal changes suggestive of a pneumonia. In summary, both cases actually have the same diagnosis and similar issues with managing at home, and yet the older person has a delay to the correct diagnosis. The second case highlights a failing of the admitting team. In this case, perhaps we should turn the label of Acopia onto the admitting doctor, who has failed to make the correct diagnosis and instigate the appropriate management plan. This next slide summarises the results of a retrospective study in a district general hospital of patients presenting with an A&E triage diagnosis of Acopia between January 2005 and March 2006. 93 cases were identified, and of these, Due to note availability, 81 cases were reviewed. Of these patients, 22% died during admission, 29% had a discharge diagnosis of sepsis, 47% presented with a classic geriatric syndrome such as falls, immobility or confusion, and only 6% had no active medical problems identified. Classic medical school education teaches us to take a history and examine one system. This creates physicians that aren't good at treating more than one problem. Comprehensive geriatric assessment is used by geriatricians to make a multidimensional, multidisciplinary assessment of a frail older person. When you see older patients in hospital, remember your geriatric giants. These are instability, immobility, intellectual impairment, incontinence, and iatrogenesis. Try to consider the bigger picture. So let's revisit our learning outcomes. Now you should know that acopia is not a medical diagnosis, and those using it as such demonstrate a lack of understanding and clinical skills when dealing with older patients. Remember that sepsis was a common listed discharge diagnosis in people labelled with acopia on admission. A diagnosis of acopia is also associated with significant morbidity and mortality. These are my references and resources. As acopia is not a true medical diagnosis, it is difficult to refer you to one valuable resource, but if you wish to understand more about comprehensive geriatric assessment, I can refer you to the summary that is available on the British Geriatric Society website. Thank you for listening, and remember that other mini-gems are available here also for your use.